Hi, my name is Rita and I am a freshman in the School of Nursing at the University of Michigan. For my video project, I assessed a 51-year-old male who is an orthopedic spine surgeon of Asian Indian descent and resides in a suburb right outside Detroit. The patient's vital signs consisted of a temperature of 98.6 degrees Fahrenheit, a blood pressure of 122/64, a heart rate of 76 beats per minute, and a respiratory rate of 17. He makes routine visits to his primary care physician as his source of medical care. The patient's chief complaint was numbness, tingling, and burning in the feet. The patient reports the problem has been progressively getting worse over the last 2 years. The numbness, tingling, and burning sensation is only felt in the feet and doesn't radiate up the legs. The patient describes the intensity as mild and the quality as irritating. Although the chief complaint does not interfere with his daily interactions, the patient stated the problem occurs nightly and it is aggravated by prolonged walking, precipitated by extreme cold, and alleviated at rest. The patient has attempted to treat the burning sensation in his feet with hot packs and claims he believes the problem is probably neuropathy due to his diabetes. The patient was diagnosed with type 2 diabetes and hypothyroidism in 2001 and also has a past medical history of ulcers and high blood pressure. He has never had cancer, never had a stroke or a myocardial infarction, or asthma. The only chronic illnesses the patient has a history of and still struggles with today is type 2 diabetes and high blood pressure. The patient stated he had no psychological issues or chronic childhood illnesses to report. The patient is up to date on his immunizations for hepatitis B, tetanus, and smallpox. In addition, he received the measles vaccine as a child. He has no environmental allergies or reactions to drugs. The patient has never undergone surgery and never been hospitalized. The patient takes many medications to uphold his health, including Tujulio insulin 50 units once per night, as well as NPH insulin during mealtimes to maintain his blood sugar. For the NPH insulin, he judges the dosage based on the sliding scale. He also takes Synthroid 88 micrograms daily for his hypothyroidism, as well as Lipitor 10 milligrams daily for high cholesterol, and glucophage extended release 2,000 milligrams daily to treat his type 2 diabetes. The patient also takes 1 baby aspirin per day as a precaution against a heart attack. The patient does not use any recreational drugs, nor does he drink or smoke. He exercises 3 times weekly by either playing tennis or walking on a treadmill, as well as lifting weights. The patient sleeps 8 to 9 hours a day. During the interview, he stated he believes his nutrition could be better as he is nourished but obese. The patient intakes a mild amount of caffeine daily through drinking Diet Coke. The patient does not use any safety devices. The patient has a good relationship with all of his family members, including his wife and their 2 children. The patient claims his wife and him have had a stable marriage for 20 years. He has a good friend group and a stable workplace. He has been employed at the same job for over 25 years. The only perceived stressors present in the patient's life are his health and children. He worries about his diabetes and acute liver issues, as well as his children's success in college. The patient is not exposed to any environmental hazards. He has no significant cultural or spiritual practices, as he is not an avid churchgoer. The patient has reached the highest level of education, earning a Doctor of Medicine postgraduate degree. His patterns of healthcare include routine visits to his primary care doctor as well as specialists when needed. The patient's paternal grandfather suffered liver failure due to alcohol, and his father was diagnosed with idiopathic pulmonary fibrosis as well as diabetes and obesity. The patient's mother is very healthy in her old age, and her only medical issue is increased cholesterol. During the interview, the patient described his health as just below average. He has been diabetic for 16 years and takes 4 to 5 medications daily as well as insulin injections regularly. Last year, he had issues with his liver, which are now taken care of. He claimed that he is satisfied with taking care of his problems the best he can. The patient's weight has gone up a few pounds in the last year. It has fluctuated between 230 and 247 pounds in the last couple of years. He claimed his energy level is stable. The patient claimed he does not have any fevers, chills, or night sweats. He also does not feel any excessive fatigue. The only new problem the patient has noticed is worsening cold intolerance. During the interaction, the patient claimed that in the Michigan winters, his feet become very cold, causing him to use a portable electronic heater very often. The first system that I interviewed the patient on was his skin. The patient claimed he has extremely dry skin, but this is not a new observation as he has had dry skin for years. The patient reports some itching last year due to liver issues, but the problem as well as the itching has subsided. He has not noticed any new skin conditions that evoke any concern. He doesn't spend long periods of time in the sun and has never used sunscreen. The patient has recently noticed some slight clubbing of the nails in both pinky fingers. The second system that I interviewed the patient on was the peripheral vascular system. The patient reported no pain in the legs, calves, thighs, or hips when walking. He claims he has dependent edema in his legs and hair loss below the knees. He has no history of blood clots in his legs and has no varicose veins. During the interview, I asked the patient if there was anything else he felt I needed to know. The patient mentioned problems with his liver that were never solved. He claimed that last year he had a routine blood test done to monitor his diabetes when he found out that his enzyme levels were elevated. After finding this abnormality, the patient had a liver biopsy conducted, but the results were inconclusive. Healthcare professionals initially thought that this was due to his daily Lipitor, but despite stopping the medication, his liver functions continued to worsen. He was put on steroids for 3 months, which fixed the problem. The patient was tested for hepatitis, and the results returned negative. The patient does have increased risk factors for hepatitis because of his work involving blood products in the operating room. The patient claimed during the interview that his symptoms from the liver issues have subsided and he is hoping that it was a one-time only occurrence. The first physical examination that I performed on the patient was on his integumentary system. The first thing I did while assessing the patient's skin was I inspected the scalp looking for lesions and flaking. Upon inspection, I only noticed a little bit of dandruff, which the patient stated was normal. No lesions or cysts were seen on the scalp. Next, I inspected the scalp and body for hair. The amount of hair was normal on the head. There was a small amount of balding and the color was gray due to age. The distribution of hair on the head and arms were symmetric in amount and texture. However, on the lower portion of the legs, there was no hair at all bilaterally. Upon inspection of the skin for cleanliness, the patient was well groomed with no extreme perspiration and no foul body odor could be smelled. The color and tone of the patient's skin was even throughout the body and congruent with a person of Asian Indian descent. I also palpated the patient's skin, feeling for moisture, texture, thickness, temperature, turgor, edema, and lesions and scars. The upper portion of the patient's body was well moisturized and with soft texture, appropriate thickness for weight, and no lesions or scars. The temperature of the upper extremities was warm bilaterally and showed no signs of tenting or edema. The lower extremities of the patient's body were dry, leathery, thicker than the rest of the body, and had some scars from previous injuries. The temperature of the lower extremities was cool and showed no signs of tenting. However, upon palpation of the lower extremities, grade 1 edema was present. The last portion of the integumentary assessment was inspecting the nails. The patient's nails were clean and cut to an appropriate length, and the color was pink. The shape of the nails was round with some clubbing and increased thickness. The attachment point of the nails was slightly concave. The next physical assessment that I performed on the patient was on the peripheral vascular system. The first thing I did while assessing the peripheral vascular system was inspect the lower extremities. Upon inspection, I found the lower legs to be dry, shiny, hairless, and showing signs of edema. The lower legs showed no signs of ulcers or varicosities. Inspection of healthy lower extremities would show symmetric, pinky color bilaterally with no extreme dryness or moisture, even hair distribution, no pitting, varicosities, or ulcers. The next thing I did was I palpated all the pulses and graded them on a scale from 0 to 4+, with 2+ being normal. I graded the temporal and the carotid, both 2+, which is normal. The brachial, I gave a grade of 1+, as it was slightly less palpable due to the patient's weight. The radial pulses I assessed at the same time, and I graded them 2+ with symmetry. The femoral and the popliteal both received a grade of 2+. The posterior tibial and the dorsalis pedis pulses received a grade of 1+, as they were weak. After palpating and grading the pulses of the upper extremities and lower extremities, I palpated the lower extremities for varicosities, tenderness, edema, and warmth. Upon palpating the lower extremities, I noticed edema, which I gave a grade of 1 because the pitting was approximately 2 centimeters deep. I also noticed a cool temperature of the legs, but no varicosities or tenderness. The last part of assessing the peripheral vascular system was conducting a capillary refill test on the patient's fingers and toes. The patient's capillary refill time was a little bit slower than normal at about 3 seconds. A head, ears, eyes, nose, and throat assessment should also be conducted. I noticed that the patient was wearing glasses during the interview and physical assessment, and due to his type 2 diabetes, his eyesight should be monitored. Doing a heat exam would identify diabetic eye disease, which includes diabetic retinopathy, diabetic macular edema, cataracts, and glaucoma. These diseases need to be caught early because they worsen with time and can result in eventual blindness. Doing a head, ears, eyes, nose, and throat exam would highlight any eye problems, which could then be recorded and monitored over time. A neurological assessment should also be conducted on the patient because diabetes is one of the most common causes for many neurological issues. For example, according to the University of Tennessee Health Science Center, approximately 25% of diabetic deaths can be attributed to strokes. In addition, studies showed that diabetes is the leading cause of peripheral polyneuropathy. Conducting a neurological assessment on the patient with diabetes can display initial signs of these diseases and many others early enough for beneficial treatment.